Welcome back to the deep dive. We're jumping right in today with congenital vascular malformations, CVMs for short.
That's right, a topic suggested by you, actually. You sent over some pretty detailed medical literature and asked us to, well, unpack it.
Exactly. So CVMs, let's start at the beginning. What are we talking about here, fundamentally?
Fundamentally, they're about blood vessels or lymphatic vessels that just didn't form quite right during embryonic development. So they're malformed
Yeah.
and they're present right from birth.
Present from birth, okay. But you might not see them immediately.
That's a key point, yeah. While the malformation is there, it might not be visible or cause problems until later.
And it sounds like it's not just one single condition. The sources really stress the variety here.
Oh, absolutely. It's a really wide spectrum. You can have issues with arteries, veins, lymphatic vessels, or, combinations of these systems. It's complex.
Okay, so our goal today is to sort of distill the key information from these sources. We want to cover the basics, causes, types, diagnosis, treatment, without getting totally lost in the weeds.
Precisely. Aiming for clarity and practical understanding. And actually, the literature brings up a really common confusion point right away that we should probably tackle first.
Which is?
The difference between CVMs and infantile hemangiomas. People mix these up all the time.
Ah, yes, that came up repeatedly. What's the crucial distinction we need to keep in mind?
Okay, think of it like this. Hemangiomas are basically vascular tumors. They usually pop up after birth, grow really fast for a while.
Right.
And then, this is the key bit, they tend to shrink and often disappear over time. They regress.
Okay, they go away on their own.
Mostly, yes. CVMs, though, are malformations, structural issues. They're there at birth, even if hidden, and they grow proportionally with the child. They don't just vanish.
That's a super helpful distinction, so CVMs stick around and grow with you.
Essentially, yes.
All right, let's dive into how these CVMs are actually classified. It sounds like the terminology itself has been a bit of a journey.
It really has. Older terms like angiodysplasia cause a lot of confusion. And even calling things like venous malformations hemangiomas, specifically cavernous or capillary hemangiomas, was common but incorrect.
So accurate naming is really important now.
Hugely important. For diagnosis, for treatment planning, for research, you need everyone speaking the same language.
So what's the system people use now? The sources mention the Hamburg classification.
Yes, the Hamburg classification is a really central framework. It's comprehensive. It looks at the anatomy, the histology, so the cell types involved,
Okay.
the pathophysiology, which is how it affects function, and the hemodynamics, the blood flow characteristics. And crucially, it links all this back to the specific stage of embryonic development where things went wrong.
So it traces the problem right back to its origins in the embryo. What are the main categories it uses?
Originally, it defined 5 main types: arterial malformation, AM, venous malformation, VM, arteriovenous malformation, AVM, lymphatic malformation, LM, and then combined vascular malformations, HLM. And later, capillary malformations, CMs, were formally added because they're clinically significant too.
Okay, and there's another layer to this classification, right? The extra-truncular versus truncular forms. What's that about?
Yeah, this is a really critical distinction, actually. It relates directly to when in development the error occurred. Extratruncular forms happen earlier, during what's called the reticular stage, before the main vessel trunks are fully formed.
Before the major highways are built, sort of?
Kinda, yeah. Truncular forms develop later during the actual formation of those major arteries, veins, and lymphatic trunks.
And why does that timing matter so much clinically?
It matters a lot for how the CVM behaves. Extratruncular lesions, because they originate from that earlier, more primitive stage, their cells kind of retain some potential to grow, to proliferate, and importantly, to recur after treatment. They often spread out more, without clear borders.
Okay, so they can be harder to fully get rid of.
Potentially, yes. Truncular lesions, developing later, their cells are more differentiated, more mature in a way. They don't typically have that same proliferative drive.
So less recurrence risk, maybe.
Generally, yes. But because they involve the main vessels, they can have really significant immediate effects on blood flow. The hemodynamics can be dramatically altered. So the Hamburg distinction really helps predict behavior and guide treatment strategy. Extratruncular often needs a more definitive, sometimes aggressive approach to prevent recurrence, while truncular might be more about managing the specific hemodynamic consequences.
That makes the difference much clearer. Now, the sources also mentioned the ISSVA classification. How does that fit in?
Right, so while Hamburg gives that developmental and anatomical view, ISSVA adds a functional layer by focusing on blood flow speed. It classifies lesions as either fast flow or slow flow.
Fast flow like AVMs, slow flow like VMs or LMs.
Exactly. And this is incredibly helpful for clinical management, for understanding the immediate circulatory impact. It also incorporates some of the older naming conventions, which you still see sometimes. Often, clinicians kind of blend aspects of both Hamburg and ISSVA to get the full picture.
So you might use Hamburg to understand the underlying nature and potential for a recurrence,
Uh-huh.
and ISSVA to guide immediate decisions based on how the blood is actually flowing.
Precisely. They complement each other really well.
Okay, let's talk about how common these are, the incidences. Sounds like getting solid numbers has been tough.
It really has. Because the definitions and diagnostic methods used to be so inconsistent, comparing old studies is, well, difficult. You see a pretty wide range of reported rates. That Kennedy study, for instance, looked at a huge number of births and found about 1%, maybe a bit more, but noted variability.
Right. What about more recent data?
A more focused study on 3-year-olds found a total CVM incidence around 1.2%. Breaking that down. VMs or AVMs were about 0.45%, CMs 0.42%, LMs 0.14%, and then the mixed CVMs were actually around 0.34%.
Interesting. So while we often hear VMs are the most common single type,
Which extra-truncular VMs certainly are frequently seen.
it looks like the combined or mixed types might actually be more prevalent overall when you add them up.
That seems to be the case, yeah. Combinations involving different vessel types appear quite common, and the data generally shows a pretty even split between males and females.
Okay, let's move on to the why, the etiology. The sources were clear that it's not as simple as just inheriting them.
Definitely not. The old idea that all congenital issues were purely inherited is outdated. While genetics is a huge factor, we now know it's more complicated. Various things have been implicated. Exposure to damaging chemicals, especially early in pregnancy.
Like the first trimester.
Yes, that critical period. Also, certain infections like rubella, drugs like thalidomide historically anyway,
Yeah.
and potentially maternal factors too, things like alcohol, tobacco, maybe even conditions like maternal goiter or diabetes have been looked at.
But genetics is still a big piece of the puzzle.
Oh, absolutely crucial. Most CVMs are sporadic. They just happen without a family history.
Huh.
But we have confirmed autosomal dominant inheritance patterns in some families, and specific gene mutations linked to angiogenesis, that's blood vessel formation, have been found.
Like the TIE2-TEC gene.
Exactly. Mutations there are linked to certain familial CVMs and also some sporadic venous malformations.
And what about VEGF, vascular endothelial growth factor? How does that fit in?
VEGF is like a master regulator for blood vessel growth. The thinking is, if the endothelial cells lining the vessels don't respond properly to VEGF signals, maybe the receptors are faulty or the signaling pathway is disrupted, then the normal process of vessel development and maturation gets derailed. The vessels might stay in a more primitive embryonic state, leading to a CVM. Think of VEGF as the project manager for vessel building. Faulty signals mess up the construction.
Got it. And there were other genetic links mentioned, like the HLA locus.
Right, on chromosome 6, there seems to be an association there, particularly with truncular venous malformations. Specifically, copy number variations, deletions, or duplications of DNA in that region seem to increase susceptibility. It's a complex area with lots of genes.
Suggesting a predisposition in some people?
Potentially, yes. It's an active area of research.
And what about things like matrix metalloproteinase 9 or progesterone receptors influencing how VMs behave?
Yeah, there's some evidence. Increased MMP9 might contribute to how some VMs invade muscle tissue, and finding progesterone receptors in VMs suggests hormones could play a role in their growth or changes over time, maybe explaining why some worsen during puberty or pregnancy.
Interesting. Lastly, on etiology, the sources mention specific genetic syndromes that feature CVMs.
Yes, there are several. Hereditary hemorrhagic telangiectasia, HHT, is one. CMAVM syndrome, linked to RC1 gene mutations, involves both capillary and arteriovenous malformations. Parkes-Weber syndrome can also involve RSA1 mutations, often leading to AVMs. And PTN gene mutations are associated with syndromes involving tissue overgrowth and often more aggressive AVMs.
It really highlights how complex the interplay between genes and environment can be. Okay, let's shift to embryology, how the vascular system actually develops. Understanding this seems key.
Absolutely fundamental. Proper vascular development is obviously critical for the embryo. Angiogenesis, forming new vessels, is an incredibly intricate step-by-step process. And because it's so complex, it's perhaps more vulnerable to errors than some other tissues.
Where do the very first blood vessels come from?
They start from cell clusters called the blood islands of Pander. These go through a whole series of changes to eventually form an initial sort of basic capillary network. This network then remodels itself into a more organized net-like or reticular structure.
The reticular stage you mentioned earlier.
Exactly. That network meets the embryo's needs during its early growth spurt.
And then comes the truncular stage.
Right. After the reticular stage, the major vessel trunks, the main arteries, veins, and lymphatic channels start to form properly. And again, the characteristics of the cells, their potential is different between these two stages. An interruption in the extra-truncular, reticular stage leads to those lesions with proliferative potential.
While interruptions in the later truncular stage lead to malformations of the main vessels themselves without that same growth potential.
You've got it. That distinction is really central to understanding CVMs.
Okay, now let's connect that to how these malformations actually affect the body. Pathophysiology, the mechanical and hemodynamic side of things.
Right. We can basically think about their impact in two main ways. There's the mechanical effect, just the physical presence of the lesion pressing on or distorting nearby structures. And then there's the hemodynamic effect, how it messes with the normal flow of blood or lymph fluid.
And which effect dominates depends on the type of CVM.
Yes. And whether it's extratruncular or truncular. Extratruncular lesions can cause both mechanical and hemodynamic problems. Early on, the mechanical impact might be slight if they're slow growing, but if they expand quickly or are in a tight spot, even a little compression matters.
But hemodynamically,
The hemodynamic impact of extratruncular lesions, especially high-flow ones like AVMs, is often more significant. That direct artery-to-vein shunting bypasses the normal capillary resistance, causing major flow changes.
and truncular lesions, are they mainly hemodynamic?
Primarily, yes. Their impact depends on which major vessel is affected. A truncular LM disrupts lymph flow, causing lymphedema. A truncular VM, say affecting a major leg vein, might cause chronic venous insufficiency. If it's a venous aneurysm, you worry about clots and emboli. And truncular AVMs, though rare, cause severe hemodynamic disruption due to that direct high-flow shunt.
The sources also mention secondary organ impact. What does that entail?
That means the CVM doesn't just affect the vessels, it can have knock-on effects elsewhere. A classic example is a CVM within bone stimulating the growth plate, leading to one leg growing longer than the other.
Which can then cause scoliosis, a curve in the spine, as the body compensates.
Exactly. Or depending on location, CVMs could affect the gut, the heart, the lungs. It depends where the malformation is and how severe it is.
Let's talk about how these actually look, the clinical presentation. Again, sounds like a huge range.
It absolutely is. For extratruncular types, it really varies depending on which vessels are involved: capillary, venous, lymphatic, arterial, where it is, and how widespread it is. Truncular types might show up as vessel bulges like aneurysms, big varicose-like veins called phlebiktasias, or just swelling from congenital lymphedema. And remember that iceberg analogy, what you see on the surface might be hiding a much larger lesion underneath.
So, given that extratruncular lesions start earlier and can keep growing, how does that typically present?
Because they can infiltrate different tissue layers and don't always have clear boundaries, their appearance can be really diverse. It might be a subtle skin change or a noticeable mass, or it could cause functional problems depending on where it is and how much it grows.
Okay, let's break it down by type. Capillary malformations, CMs, what's the typical look?
The classic CM is a port wine stain. It's a flat, reddish-purple mark on the skin present at birth. Different from common birthmarks like stork bites, they can be anywhere, any size. And importantly, sometimes a CM, especially on the face, can signal underlying issues, like in Sturge-Weber syndrome, where it's linked to brain vascular malformations.
Got it. What about venous malformations, VMs? What do they usually look like?
VMs often appear as soft, bluish swellings under the skin. You might notice them at birth or maybe later. They're usually compressible. You can squish them down.
And they change with position.
Yes, typically they get bigger or fuller if the area is hanging down or if the person strains, like with a Valsalva maneuver.
Yeah.
They tend to grow slowly and can cause pain or stiffness, sometimes worse in the morning.
And complications.
Depending on location, yeah. They can affect bone growth, leading to limb length differences, cause joint bleeding, clots, even GI bleeding if they're in the gut. Head and neck VMs can be disfiguring or even block the airway.
Okay. Lymphatic malformations, LMs.
LMs can be either diffuse swelling of a limb that's primary lymphedema or more localized bubbly swellings called lymphangiomas, which are basically collections of abnormal lymphatic channels. They can feel soft or firm.
Are they usually painful?
Often not, unless complications develop, like fluid leakage, bleeding into the lesion, or infection. But if they're in the mouth or tongue, they can cause pain or bleeding. Around the eye, they can affect vision. In the face or neck, they might interfere with chewing or breathing. And bone involvement can cause overgrowth or fragility fractures, like in Gorham syndrome.
Arteriovenous malformations, AVMs, these sound potentially more dramatic.
They often are, or can become so. Small ones might be subtle initially, but as they progress, you can get localized swelling that feels warm to the touch. You might feel a vibration, a thrill, or hear a whooshing sound with a stethoscope, a brute. Nearby veins might become enlarged and visible. And downstream effects. Yes. The tissues beyond the AVM might not get enough blood, leading to ischemic changes, skin breakdown, ulcers, pain, bleeding. In severe cases, the constant high flow through the AVM can overload the heart, causing high-output cardiac failure. Or you could even get gangrene in the affected limb.
Wow. Okay, and finally the combined types like HLMs in Klippel-Trenaunay or Parks-Weber.
Right. In these syndromes, the clinical picture is a mix of the features from the different CVM types involved. So you might see capillary stains, lymphatic swelling, venous issues, and sometimes AVMs. Overgrowth of the affected limb, both soft tissue and bone, is really common.
Like in KTS.
Exactly. Klippel-Trenaunay typically has the port wine stain, the limb hypertrophy, and those large varicose-type veins, often including a prominent marginal vein along the side of the limb.
And Parks-Weber.
Parks-Weber looks similar superficially. The stain, the overgrowth, the veins, but the key difference is the presence of an AVM. That's why you can often feel a pulse or thrill in PWS, which you typically don't in KTS. These combined types can also affect internal organs sometimes.
This sheer variety really drives home the need for accurate diagnosis. What are the key steps involved?
Well, it often starts with clinical suspicion, a baby or child with unusual swelling or a birthmark. A really careful history and a thorough physical exam are paramount. And as we said, ruling out infantile hemangioma first is critical because one CVM type can sometimes hide another. A full workup, often looking beyond the obvious lesion, is usually needed. The main goal is to pin down the exact type and subtype of the CVM.
What does that physical exam involve specifically?
Looking closely at and feeling all skin surfaces, listening for brutes and feeling for thrills or abnormal pulses if you suspect an AVM. Examining the patient both standing and lying down is important, especially for VMs, to see how gravity affects them. The limb elevation test helps identify VMs too, and for AVMs, assessing the impact on the heart and overall circulation is key.
Imaging must be crucial then.
Absolutely vital. Imaging confirms the type, shows the extent, and rules out other associated malformations. Luckily, non-invasive or minimally invasive techniques are often enough.
Like MRI.
Yes, MRI, especially T2-weighted sequences, is fantastic for visualizing VMs, often called the gold standard. Duplex ultrasound is another workhorse readily available, very useful.
What else?
Whole-body blood pool scintigraphy can show abnormal blood pooling in VMs and help distinguish them from LMs. If you suspect an LM, radionuclide lymphoscintigraphy is the go-to. For AVMs, CT scans with contrast and 3D reconstruction are usually essential. And for quantifying shunt flow in AVMs, especially subtle shunting like in PWS, transarterial lung perfusion scintigraphy, or TLPS, can be used. There are other specialized MR and ultrasound techniques, too, for vessels and lymphatics.
When would you need more invasive tests, like angiography?
Usually for therapeutic planning, especially for AVMs where you need a detailed map before intervening, or if the diagnosis is still uncertain after non-invasive tests. Standard arteriography is still the definitive test for AVMs. For VMs, different types of phlebography, injecting dye into veins, including direct puncture, can map them out for treatment. Traditional lymphangiography is rarely done now due to risks.
And sometimes you need to check other affected systems too.
Definitely. If there's a leg length difference, a bone scanogram measures it precisely. Coagulation tests aren't routine for all CVMs, but you do them for extensive VMs, marginal veins, suspected clots, or signs of consumptive coagulopathy.
Okay, so circling back to diagnosis, differentiating CVMs from infantile hemangiomas, let's quickly recap the key differences.
Sure. Infantile hemangioma appears after birth, grows rapidly, then shrinks, involution, more common in girls. CVM present at birth, even if not obvious, grows with a child, doesn't shrink, equal gender distribution. Imaging like ultrasound or MRI confirms it. And fundamentally, CVMs are malformations, structural errors, not tumors like hemangiomas.
And differentiating between CVM types is also critical, especially finding hidden AVMs.
Hugely important. An AVM component changes the whole picture, the risks, the treatment approach. So even if it looks like a straightforward VM or LM, you have to be alert for an underlying, maybe subtle AVM. Tests like TLPS, CT angiography, or standard arteriography might be needed to rule it out. Sometimes analyzing fluid aspirated from a lesion can help too.
This naturally leads us to treatment. The sources suggest approaches have really changed over time.
They really have. In the past, overly aggressive surgery sometimes had poor results, high recurrence. Now, the focus is much more on multidisciplinary teams, getting surgeons, interventional radiologists, dermatologists, hematologists, etc., all involved. And understanding that extra-truncular versus truncular distinction is key to planning.
So what are the main options now?
Broadly, you have traditional surgery cutting the lesion out for ones considered surgically accessible. And you have endovascular therapy, embolization, or sclerotherapy, done through catheters or direct injection for lesions often deemed surgically inaccessible. Very often, though, a combination of both is used.
How does the extratruncular nature affect treatment?
Because they can regrow if not fully dealt with, extratruncular lesions often need a, well, controlled but aggressive approach aiming to completely destroy or remove the core, the nidus. Just partially treating them can actually stimulate them to grow back. Those really diffuse infiltrating ones are the toughest challenge.
And truncular lesions, different strategy.
Often, yes. Since they don't have that same regrowth potential, such an aggressive approach isn't always necessary or justified. Some can be watched carefully unless they cause significant hemodynamic problems or specific complications like clots or venous insufficiency. Then you might intervene surgically, reconstruction or ablation, or endovascularly, but always after checking the deep veins are okay.
Are there specific reasons or indications for treating a CVM? Not every single one needs intervention, right?
Exactly. It's a very individualized decision made by the team. Generally, treatment is indicated for things like bleeding, high-output heart failure from an ECM, ischemia, lack of blood flow, chronic venous problems if it's threatening life or function due to location, causing severe pain or functional impairment, major cosmetic issues, causing vascular bone syndrome, high risk of complications like clots, or persistent lymphatic leaks or infections.
Let's get into the specifics of treatment, starting with endovascular options, embolization and sclerotherapy.
Right. These have become really central, especially for those difficult, diffuse, surgically hard-to-reach extratruncular lesions. They're also used a lot before surgery to shrink the lesion and reduce bleeding, or after surgery to clean up any remnants.
Sclerotherapy, injecting stuff to destroy the vessels. What agents are used?
Absolute ethanol is very potent, can potentially cure, but it's highest risk of serious heart and lung side effects. Needs very careful monitoring, usually under anesthesia, strict dose limits. But it's still a primary choice for severe CVMs, including AVMs sometimes.
Safer options.
Yes, for less aggressive VMs or LMs, agents like ethibloc, polydocanol, sodium tetradecyl sulfate are often used. They're generally safer. Foam sclerotherapy, mixing the sclerosant with air, can be good for superficial lesions, but you have to watch for potential air embolism.
Okay. And embolotherapy, using materials to block flow.
Exactly. Things like special glues and BCA,
Yeah.
onyx, a liquid embolic, metal coils, or tiny particles. These work by physically blocking the vessels. The downside is they don't usually destroy the vessel lining like sclerosants do, so the risk of the lesion reopening or finding new pathways, recurrence, can be higher if used alone.
So often used in combination.
Very often, especially pre-op for AVMs or large VMs to make surgery safer. Coils are good for blocking larger feeding vessels and high-flow AVMs, maybe converting them to lower-flow lesions that can then be treated with sclerotherapy or surgery.
What about actual surgical therapy?
Resective surgery, cutting it out, is really the only shot at a cure, but only if you can remove the entire lesion, which often means a radical operation with potentially high morbidity. If you leave any behind, especially with extratruncular types, it's likely to come back. So it's best for more limited, localized lesions.
But most CVMs don't need that kind of radical resection.
Correct, apart from perhaps some AVMs. Reconstructive surgery is more for truncular VMs, affecting major veins, things like repairing narrowed segments, removing webs, bypassing blockages, or fixing aneurysms. Sometimes endovascular techniques like angioplasty and stenting can achieve similar results for blocked major veins.
Okay. The sources also flag some special treatment issues. Congenital vascular bone syndrome, CVBS. Tell us about that.
Right, CVBS, or angio-osteodystrophy. This is when a CVM, usually near a long bone, affects bone growth. It can cause the limb to grow too long, hypertrophy, or stay too short, hypontrophy. That marginal vein in KTS is a known cause of overgrowth.
How does it cause that?
It's thought to be due to altered blood flow near the growth plate, possibly involving growth factors too. Overgrowth might be from increased blood supply, undergrowth from compression or reduced flow. You spot it clinically by seeing a leg length difference alongside a CVM, author of VM, confirmed with x-rays and a scanogram.
In treat?
The key is early, aggressive control of the CVM itself, ideally before the growth plates close around age 16-18. Removing the CVM early might allow the body to naturally compensate somewhat for the length difference. Orthopedic procedures might be needed later, after growth stops, but you generally avoid operating on the healthy leg during growth.
Another challenge, coagulopathy, clotting problems.
Yes, particularly with extra-truncular VMs. Because blood flow inside them is slow and stagnant, you can get localized clotting, localized intravascular coagulopathy, or LIC. The body tries to break down these tiny clots, which leads to elevated D-dimer levels.
And phlebolyths.
Exactly, those small calcified clots, phlebolyths, form within the VM over time. While LIC is usually confined to the lesion, it can sometimes lead to DVT, pulmonary embolism, or rarely, more widespread clotting issues like DIC, especially as triggered by surgery, sclerotherapy, trauma, or even pregnancy.
So how is it managed?
The presence of lots of phlebolyths, especially in big VMs, might signal higher risk and a need for anticoagulation. It's important to distinguish LIC from Casabuck-Merritt syndrome, which is different, occurs with vascular tumors and causes severe low platelets, unlike the usually mild platelet changes in LIC. All VM patients should probably have their thrombotic risk assessed, and detailed clotting tests are needed before major procedures, especially if D-dimers are high or fibrinogen is low.
Okay, and briefly, managing the syndromes. Klippel-Trenaunay.
KTS management often starts conservatively: compression stockings, sclerotherapy for problematic veins. Surgery to remove varicose veins needs caution because the deep veins might be underdeveloped. If the deep system is normal, staged surgery might help, followed by sclerotherapy. Excising a large marginal vein might be considered, again, if deep veins are okay. Preventing clots is also crucial. And the lymphatic component can be a big issue too.
And Parks-Weber syndrome.
PWS looks similar to ATS, but has that underlying AVM. So the treatment focus is different. It's about controlling the arteriovenous shunting, usually with embolization therapy. The prognosis and clinical course are generally different from KTS because of that AVM.
Given everything we've discussed, long-term follow-up sounds absolutely necessary.
It really is essential. How a CVM behaves long-term depends partly on its embryonic origin. Those extra-truncular ones can potentially keep growing or reactivate. Any CVM in a limb needs watching closely until growth stops. Hormonal changes, especially in female patients, can trigger changes. Trauma, surgery, pregnancy, these can all reactivate dormant lesions. So, yeah, lifetime follow-up with regular check-ins and appropriate imaging is usually needed, whether the lesion was treated or just being monitored.
This has been incredibly informative, a real deep dive. Just to quickly summarize the big takeaways. CVMs start in embryonic development. They're distinct from hemangiomas. Classification, like Hamburg and ISSVA, is key. Diagnosis needs careful clinical assessment plus imaging. And treatment is multidisciplinary, tailored, often combining approaches, and requires understanding the specific type, like extra-truncular versus truncular.
Exactly. We've covered a lot of ground based on the sources you provided. Hopefully this gives you a solid foundation. And as you said at the start, this might spark further questions for you, maybe wanting to look deeper into specific types or treatments.
Absolutely. And perhaps a final thought to leave you with. The field is constantly evolving. Research is ongoing, leading to better understanding, improved diagnosis, and hopefully more targeted and effective treatments down the line. It really highlights how dynamic medicine is and why continuing to learn is so important. Thanks for joining us on the Deep Dive.